These are the 20 steps for positioning a patient for a Nasium. The patient would be in a gown, in stocking feet, all artifacts removed. I need you to come on over here and have a seat for me, please. Scoot your hips into the back of the seat, sitting up good, straight, and tall. Feet on the pegs, hands on your lap, looking straight ahead. Next, we're going to place the anatomical marker, which goes in the lower corner of our 10 by 12 field. Cassette is a 10 by 12, which we're going to place in the 10 by 12 position inside the bucky. So lining up the cassette clip arrow at the 10 by 12 designation in the bucky, locking our cassette in tight. Next, we're going to measure our patient. For a Nasium, the base of the caliper goes at the patient's EOP, and the blade goes to the front of the patient to the lower third of the nose, which is between the bridge and the tip of the nose. Measuring in centimeters, she's between 20 and 21 centimeters. So we're going to set our exposure for 21 centimeters on the Nasium chart. It's calling for 66 on the KV, 150 on the MA. Skip the time, we're going to check that last. It's calling for 22.5 on the MAS. Now we check the time window and make sure that the time on the chart matches the time in our window, which is 0.150. So everything is set correctly. We're going to perform normal head carriage on the patient. Can you please go ahead and tuck your hair behind your ears? And I'm going to mark some points on your face. Is that all right? It is. Okay. We're going to mark the transverse process of C1 on both sides. Okay. And I'm going to ask you to close your eyes. May I touch your chin?
Yes.
I'm going to mark you between the eyes and above the top lip, center of the symphysis menti, and the center of the episternal notch. So assessing for normal head carriage, keeping your eyes closed. I need you to tip your chin up towards the ceiling and come back down to what you feel is level with the horizon. Noting the canthus line, it looks parallel to the floor. Keeping your eyes closed, drop your chin against your chest and come back up to what you feel is level with the horizon. And again, she's holding her canthus line or her hard palate parallel to the floor. Okay, so you would note that and express that to your testing doctor. I'm going to turn you toward me. I'm going to touch your shoulders lightly. I want you to turn your head to the side that I tap, and then come back to what you feel is pointing straight ahead. Noting where the chin dot lands in relation to the episternal notch dot, I'm going to drop the plumb line to the landing point on the neck and mark that with a slash. Keeping your eyes closed, please turn to the opposite side and come back to what you feel is pointing straight ahead. Noting where the chin dot lands in relation to the episternal notch dot, it's landing on the first landing point. So I'm going to bisect the distance between the episternal notch and the landing point that she came back to both times, and I'm going to mark that bisection with the highest slash mark. That highest slash mark is her normal head carriage position. So I'm going to make sure that she's in that position for all the images that we take of her. Next step, I'll be setting bucky to patient. So for a Nasium, the bucky has to be in a head-shoulder angle, which means we have to look at the patient's back of her head and the back of her shoulders, which is the upper thoracic area, and see what natural angle that it forms. And the goal is to set our bucky at that angle that would match the patient's natural head-shoulder angle. But before we do this, we need to make sure that our head clamp is locked in tight, because we don't want that to fall forward and strike our patient. So I'm going to set my bucky angle at what I feel is close to her head-shoulder angle, keeping that 10 by 12 cassette field right about her head and neck area, not too high or too low. And I'm going to tell the patient I'm going to slowly roll you back towards the board. I want you to tell me what touches first, your head, your shoulders, or both. The goal is to get the head and shoulders to touch simultaneously. Okay, you just hold your natural posture and tell me what touches first.
Shoulders.
Shoulders? Okay. So because her head didn't touch, I need to change her head-shoulder angle. So I bring her off the bucky a little, so I have some room to adjust the top of the bucky closer to her head, the part that didn't touch. And we're going to back you up again. Tell me what touches first, your head, shoulders, or both.
Both.
Okay, great. That's what we want. So we've set bucky to patient, patient to bucky. Next step is tube to bucky and patient. So we're going to bring our focal film distance in until the arrow on the tube matches the 40 FFD on the track. We're going to raise our tube height. Stay at 40. And we're going to set our tube angle at 10 degrees caudal. So 40 FFD on the track, 10 degrees caudal on our tube angle. And then we're going to raise the tube until the horizontal crosshair that projects on the patient's face is through her lower third of the nose, the same point that we measured. That's our anterior facial strike point. We also need to check that beam and make sure that the posterior aspect of the beam is through the posterior facial strike range between the bottom of the tragus notch and the top of her transverse process. If that beam is through this range here, we're good. So we set the beam to the patient's first through her anterior posterior facial strike ranges, and we need to adjust this bucky up or down a little to make sure that the horizontal pinstripe for the center of the bucky superimposes that horizontal crosshair of the beam. So if I need to bring my bucky down a little, as I have to with this patient, to make this slash mark superimpose this horizontal beam, if I were to leave her in this position and bring that bucky down, it's going to push her forward, and we don't want the bucky to ever push the patient. So because my bucky has to come down a little for her, I need to first move her off the bucky just about an inch, no more than that. And I'm going to bring this bucky down to superimpose my beam. And now I'm going to back her up again. Tell me what touches, head, shoulders, or both.
Both.
Okay, let's lock her in. All right, bucky to patient, patient to bucky, tube to bucky and patient. Next step, we're going to assess her for head rotation and tilt. And if there's any, we're going to correct it. So I need you to close your eyes. Let's make sure that she is still in her normal head carriage posture. If she's not, I can touch her face and say I'm reestablishing normal head carriage, bringing the chin back in alignment with her normal head carriage position on her neck. Now that she's in normal head carriage, I need to assess the distance between her orbits and the lateral rim of the skull, looking to see if they're even. If they're even, there is no head rotation, but if one side is narrow and the other side is wide, I have to correct that head rotation by turning the chair towards the wide orbit side until the orbit's even up on both sides. That's the removal or the correction of head rotation. I'm just going to roll her back to line up with that vertical crosshair. And I'm also going to assess for head tilt. So looking and seeing if she has any head tilt, her top of her head is towards the wall. So that's tilt to the doctor's right or patient's left. So to correct for tilt, I'm going to hold my hands in this position, thumbs on her jaws, pinkies on her shoulders, and I'm going to tell her be like a statue and lean at the waist in the direction I lean you until we see no head tilt. Dots should be straight up and down on the face. Hold that position. At this point, we may need to move the patient back over. So let's say, please hold still like a statue and just slide along the board as I move you, okay?
Okay.
We're just going to go a little towards your left to line her back up with the vertical crosshair down the center of her facial dots. So we've corrected head rotation and tilt. Once you do this, go ahead and head clamp. Be careful with the head clamps. Bring down the center of the pads at the patient's earlobe. And remember, they don't squeeze, they just touch lightly, just to give the patient a little guide so they don't move too much during the picture. Okay, are they touching?
They are.
Okay. Check our beam. Okay. Next thing we're going to do is collimation. So I'm going to bring in my top and bottom collimation shutters. So I need to stand about 45 degrees in relation to the patient so that I can see the shadow of her shoulder projecting on the bucky. I can also see the light field of the tube. So I can watch my shutter, collimation shutter, rise up around the patient's shoulder. If I stand in this position, I won't be able to see my collimation shutters coming into the field. So I'm going to stand back here, and I'm watching the shutter rise up on the bucky surface, and I'm going to stop when I see it come into the 10 by 12 field. It should just barely graze the bottom of the anatomical marker. So we're going to stop there. Now we can bring in our side or vertical shutters until they pass the 10 by 12 field by about a ½ inch medially. Then we're going to stop. So collimation is done. Next, we're going to apply aluminum filtration. So we're going to be using 2 filters, a 4 millimeter thickness over the orbit and a 3 millimeter thickness over the thyroid. So let's put our 4 millimeter filter on, and it sticks to the collimator housing with magnet. 3 millimeter filter as well, sticking to the collimator housing with a magnet. And then we have to adjust the height of those filters so that the shadow of the filter covers the radiosensitive structure, the eyes or the thyroid, and doesn't come down so far that it intrudes into the horizontal beam. So the shadow of this filter is covering her eye, and I can still see a little light strip between the bottom of the filter and our horizontal crosshair on her face. And this filter usually will come up from the bottom just about to the patient's lips so that it shadows over her thyroid. Okay, so we have collimation, filtration. I'm checking the patient to make sure she hasn't moved or drifted from where I placed her. Okay, at this point we're ready to instruct our patient. We're getting ready to take your picture. Please hold still, don't move. We're going to come back here, make the exposure, and then we would relax the patient. You can relax. Remove the head clamp, lock it back in place. Okay. We're going to remove our filters. We're going to pull the patient off the bucky just a couple inches so that we can bring our bucky straight up and down so that it is safe to remove our cassette. We're going to change our cassette. New cassette would go in for the next image. I'm going to go ahead and reset my exposure factors for the next image. And I'm going to reposition the anatomical marker, or at least make sure it hasn't fallen off the bucky. And then the last step, I'm going to reestablish normal head carriage because the patient probably has drifted out of normal head carriage when I told her to relax. So we're going to bring that chin dot back into her normal head carriage posture, lining up with the high slash mark on her neck. And at this point, we're ready to proceed with the next patient's image.